The calf pump here is an example of how they work. A network of capillaries in the leg feeds into small veins or venules. These in turn lead into the superficial veins. Via the so-called perforators or perforating veins, the superficial veins are themselves linked to the deep veins, which are entirely encased in muscle or between the muscle and bone. All these veins are well supplied with valves which are integral to the effective operation of a collection and pumping system. As the large muscles surrounding the deep veins contract during walking, blood is forced up through the valves within them. At the same time, the valves in the perforating vein are forced closed, thus preventing the blood from returning to the superficial veins. When the muscles relax, the pressure decreases dramatically in the deep veins, creating a favorable pressure gradient and allowing the valves in the perforating veins to open. Blood from the superficial veins can then flow in the direction of the favorable pressure gradient which has been created. To monitor the sequence of pressure changes, cannulas were inserted in both deep and superficial veins of volunteers. Here we can see the pressure in the deep veins rise and fall considerably as the muscle activity during walking compresses the veins and then allows them to relax. The yellow trace shows the pressures recorded in the superficial veins at the same time. The pressure differences recorded in the superficial veins were relatively small, and it is only at these points, a time interval of just around 1/10 of a second, when the pressure in the deep vein is lower than that in the superficial vein. At these points, the inflow of blood from the superficial veins is permitted past the valves of the perforating veins, and the blood enters the deep veins. This transfer of pressure from the deep vein to the superficial, with subsequent dilatation of the superficial, continues relentlessly over the years as this disease progresses. Every time high pressure is created in the deep veins, it's transferred to the dilating segment of the superficial vein. As time goes by, so the dilatation of the superficial vein proceeds upwards in a proximal direction, with the vein dilating and each valve in turn showing secondary incompetence. At this stage, blood flow patterns change dramatically, with a profuse and rapid downward flow of blood, which on exercise increases in velocity and becomes turbulent as the flow impinges on the vein wall. The turbulence causes atrophy of the smooth muscle in the vein walls, where they're subject to the unnatural turbulent flow, and the characteristic bulges associated with varicose veins become apparent. During the progress of this disease, the original incompetent perforator can be obliterated by ligation, or more easily by sclerotherapy. This involves the introduction of a sclerosant into the emptied segment of the superficial vein over the site of the incompetent perforator, plus uninterrupted compression applied to the injected vein using a rubber pad. Then the leak of high pressure is prevented, and with compression and prescribed walking, the superficial vein will return to normal size and function. Frequently, patients are not referred for treatment until the later stages of the disease, when the effects of downward turbulent flow are apparent. And although we've concentrated here on the effect of just one original incompetent perforating vein, in reality, there may be more to be obliterated for the cure to be effected. The result is that the superficial veins return to their primary function of acting as cisterns,